classes, spending time learning how to do all of that. So really looking forward to seeing your final product. So, thank you.
Thank you all for being here today. Like Dr. Leach said, it's the Friday before Memorial Day, so thank you for spending time with me today. So the title of my thesis is Exploring Social-Ecological Determinants of Physical Activity Among Adult Survivors of Childhood Cancer. And we're going to dig into all of those big words here in a moment. So I'd like to orient you to the bottom of the screen here. This will show up throughout the entire presentation with an introduction, methods, results discussion, and then the final conclusions. So starting with the background. In 2018, over 10,000 children and an additional 5,000 adolescents were diagnosed with cancer in the United States. The good news is that survival rates are rising. You can see that 5 years post-therapy, the survival rate is at 80%, and for 10 years post, it's approaching 80%. And that's mostly due to advances in cancer treatment. Any of these survivors can receive any of these cancer treatments, but specifically radiation and chemotherapy are culprits of late effects of cancer treatment, including cardiovascular disease. Fortunately, physical activity is known to reduce the risk of treatment-related cardiovascular disease. So this graph here shows that the time since baseline, that's the time since treatment ended, or they tracked them over 15 years and saw that the cumulative incidence of any major cardiovascular event was significantly lower in those who were physically active. And that's shown here and measured with net hours per week. So the gold there is those that are physically active. Now, we know that physical activity is so good, but there's a problem. They're not being physically active. So compared to healthy siblings, adult survivors of childhood cancer from this point forward, we abbreviated ASCC, are not meeting the guidelines for physical activity. So the guidelines are here on the right, 150 minutes of moderate intensity exercise or 75 minutes of vigorous intensity exercise per week. Now, we know that they can be, let's hold on just a second here. So we know that physical activity is great. They're not doing it. How can we get them to be physically active? We know of some theories that have been used in the past, specifically with cancer research. One theory is the theory of planned behavior. Dr. Carrie Cornea up in Canada loves this theory. And basically takes into account an individual's attitudes, subjective norms, perceived behavioral control, all to determine their intention to be physically active. Another model that's commonly used is the health belief model, which basically takes, okay, what is the perceived benefit versus the perceived cost or threat to their health to determine their likelihood of engaging in a health-promoting behavior, such as physical activity. Finally, the trans-theoretical model, again, takes an individual from before they even think about being physically active to thinking about being physically active, preparing to be physically active, actually being physically active, and maintaining that activity. Now, these theories are great and have been used before, but these theories only account for individual level factors. So what about the factors that are outside of the individual? Think about where, if you want to be physically active, you know that there are things that are outside of yourself that influence your physical activity. So we're going to go through and explain why I chose to use the ecological model of physical activity. And this model takes into account the individual, such as their sex, age, and health, status, knowing that this individual lives in a microsystem of people, parents, peers, clinicians, school, work, local rec centers. It's where these people live, work, and play. The mesosystem and the exosystem are transitional levels that ultimately get to this macro system level. So this macro system includes the attitudes and ideologies of the culture, including socioeconomic status, to ultimately influence physical activity. I like to use the example of living in Colorado versus living in Mississippi. Living in Colorado, it's the cool thing to go hike a 14er on the weekend. In Mississippi, it's not. So all of these systems work together. So not one, there's not only one that is the primary influencer here, they all work together. So to date in childhood cancer research, there are a number of established individual factors for physical activity. And of the studies that are done in this population, only half of them are even rooted in any sort of theory. So like I had mentioned before, it's important for us to use theory to understand physical activity. And these studies only address individual level factors. Getting ahead of ourselves here. There we go. A study by Gilliam and Schwiebel looked at physical activity among child and adolescent survivors. So this is before they are adults. And looked at the barriers and facilitators to physical activity in this population and actually used the same model that I did, but applied it to only child and adolescent survivors. So the gap then is, what about adults? What happens after they reach adulthood? So the purpose of my study has two aims. The first is to categorize barriers, facilitators, and resources necessary for physical activity into the levels of the ecological model of physical activity, or the EMPA. That's what I'll call it from this point forward. And then the second aim is to identify themes that emerged through these open-ended questions. And these open-ended questions I will get to here in the methods. So, how did I do this? I did a qualitative concept elicitation study, which is a lot of really big words for a starting point. This study is a starting point for understanding and getting more information about physical activity in this population for future studies. So I used this concept elicitation method is not new. In fact, Janice Withicum was a part of a concept elicitation study looking at patient-reported outcomes in childhood cancer research, and they did a qualitative, open-ended. They did interviews here with this population, but so this is not new. This is not a new idea. Is basically what I'm saying. So who participated in this study? So I looked at adult survivors of childhood cancer and parents of adult survivors of childhood cancer for two reasons. One, because parents are critical gatekeepers of information, and that during cancer treatment. And in the spirit of using the ecological model of physical activity, I thought that it was good to bring in parents from that micro system to gain insight on physical activity in this population. So some inclusion and exclusion criteria. So an adult survivor of childhood cancer is defined as, in my study, a person who is diagnosed with any cancer before the age of 18, currently 18 to 39 years old, able to read and write in English to answer those open-ended questions so that I can understand them, and they must be ambulatory. Parents of these survivors had to have a child who fit those same criteria. So I used Qualtrics to create an open-ended survey, and the survey questions included things like demographics such as age, zip code, cancer diagnosis information, as well as a self-report of physical activity using the GODIN. And then finally, open-ended questions asking about barriers, facilitators, and resources for physical activity. And I'll get to those here in a second. So I distributed this survey using the Qualtrics link, but using, these are some of the cards that I used over on the left to recruit for my study. So if I found anybody that I knew, I could hand them that card. A sample recruitment flyer is on the right, and then I used Stupid Cancer. Stupid Cancer is an organization for young adult cancer survivors, and they have a pretty large social media presence. So I posted on their Facebook groups that are organized by region. So this is an example of the Mountain West region. There are regions all across the United States, and so I shared the link to my study and information about my study through this Facebook link across the entire United States. So the questions of interest. The three questions that I was looking at specifically were barriers. So the way that I asked for barriers to physical activity was over the last year or so, what factors have made it hard for you to be physically active on a regular basis. The facilitators was a very similar question, but instead asked what factors have made it easy for you to be physically active. And then finally, the resources question. The resources question asks which resources would you need to participate in physical activity on a regular basis. And this allowed us to get those extra individual factors that are outside of the individual and to capture those. So, in terms of analysis, this is qualitative research, so you will not see a p-value for the remaining of these slides, just a little warning there for you. So, as the first aim was to categorize these responses into each level of the EMPA. And the way that I describe this is that responses came in like a faucet, full of words that needed to be made a meaning of. So we took each droplet or answer or response and categorized it into each bucket. And each bucket was represented each level of the ecological model of physical activity. So, but I did not do this by myself. To ensure reliability, I had Ashley, who is is an MPH student who was interested in doing some qualitative research, and she helped me. We both independently coded the responses, and then we met frequently to discuss any discrepancies. There absolutely were discrepancies, and those are noted in memos. And so we would have discrepancies, and then we would come to an agreement. If we could not come to an agreement on whether an answer was coded individual, microsystem, whatever level, we reached out to our big guns over here with Dr. Leach and Dr. Chard to help arbitrate. So the next part was the next aim. So we have it all sorted into buckets, but what is in the bucket? So that's where we identified the themes that emerged in the data. So in each bucket, we did this across the board. So we had, so we basically looked and saw, okay, what themes are showing up, what categories are showing up frequently, and then that's how we identified those themes. On to results. So, in terms of survivors, there were 17 survivors who completed this study. The average age at the time of study was 26 years old. But notice that range is right exactly where I want it in terms of my inclusion criteria. So they were 19 to 39 years old. The primary diagnoses were leukemia, lymphoma, brain or central nervous system, and sarcomas, which are pretty representative of the top cancer types in this population. Next, parents. There were 8 parents who were enrolled in this study. A point to note is that the parents were not matched with survivors. So a parent could fill out the survey with the knowledge of their own survivor's experience, but their survivor didn't necessarily have to fill out the survey, and they were not matched. That allowed us to get more information about adult survivors of childhood cancer in general, whether that came from a parent perspective or a survivor. The diagnoses, again, leukemia, lymphoma, brain, CNS, and kidney, so those are, again, some top types. Important to note is that these parents provided those top data points for their survivors. So the parent filled out the survey and said, my child is female. The diagnosis that my child had was leukemia. So, on to results. This is a lot of colors here, so I'm going to orient everybody here. So on the x-axis are the questions, so the barriers, facilitators, and resources. The colors are represented by each level of the EMPA. So the green you'll see on barriers, the majority of barriers fell into the individual level of the ecological model. There were 69 total responses. And the top facilitators and resources, the majority of them fell into that microsystem, that system where people live, work, and play, right outside of the individual. That's what survivors reported. Parents, you'll see that the total number of responses is a little bit lower, but that's because we only had 8 of them compared to the 17 survivors. The barriers are pretty mixed, but facilitators and resources were consistent. Same thing with adult survivors. So most of those responses fell into the micro system. So for the second aim was to identify the themes that emerged in these open-ended responses. Okay, if you have a hard time reading them up here, you can also peek to the side with these really cool TVs we have in this room. So these are the top 7 themes that emerged from the open-ended responses. There were 102 responses in total, and I'm going to go through each of these and provide examples of what they reported. So, what's in the bucket? This is where we are. Okay, proximity and access. Proximity and access refers to how close the individual is to places where they can be physically active. Where do they have trails nearby? Do they have walkable neighborhoods? Those types of things. This showed up as a barrier facilitator and a resource. So some examples were that a barrier was the physical proximity to the area of exercise. Some resources needed a location relatively close to where I live. Social support. Social support came up next as a facilitator and a resource, and that includes support from family and friends to be physically active. And that can come from accountability, but also motivation as well. Equipment. Equipment showed up as the third theme that emerged as a facilitator and a resource necessary for physical activity. So those things included like having the gear to participate in activities that they want to be involved in. Resources, having a class, going to a class, or having an online video that they can follow. And by the way, all of these have been were reported by both parents and survivors. Time and schedule. Time and schedule emerged as the fourth theme as a barrier and a facilitator to physical activity. So some time and schedule barriers included things like school and work, starting grad school, having a busy schedule. But I love what this one survivor said, that I have more time in my schedule without worrying about homework deadlines. So saying that, okay, I'm out of school, I now have more time is what they're saying there. None. Okay, so you'll see here that none refers to participants who, when they answered the open-ended question, they wrote the word none, nothing, or NA. Which is important to mention because it should not be disregarded, because if they feel like there's nothing that could possibly help them be physically active, that's worth noting and requires further investigation. So that showed up as a barrier facilitator and a resource, and that was reported by both parents and survivors. Number 6, finances. This is the fun one. Finances emerged as a barrier and a resource for physical activity. So things like having limited financial resources, finances to afford gym costs, etc. And then finally, what I think most of you in this room would expect, that cancer survivors experience health-related barriers. So related to their cancer treatment or the cancer itself. So these emerged only as barriers to physical activity, so an exercise-related breathing issue, fatigue, pain, etc. Okay, so on to the discussion. So we have the themes there on the left, and we have the model on the right, the model that we used. And so you might be able to gather where some of these things fell, but I'm going to show them to you here. So, no, not that fast. There we go. Okay, so as you can see, most of these themes emerge at the individual and microsystem level, or the most proximal level to the individual. Okay, the exceptions to that were finances, that's that black box, and then none. And none could not be put into the model because they just said none or nothing, which does not fit. So that's why it's off to the side there. But the macro system level included finances. And so participants said things like limited financial resources, money would be helpful, money is a barrier. Okay, but what does that mean? And so we don't necessarily know what those participants mean when they say those things. So that requires further investigation, and I think that semi-structured interviews and focus groups would help allow us to get a more breadth of understanding about finances in this population. Also, the same thing with none. So if they say, oh, nothing will help me, well, why is that? What do you mean by that? See if any additional probing would allow for a greater understanding. So, some strengths and limitations. The first strength is applying a social-ecological framework to this research. That allowed us to get a very comprehensive understanding of physical activity in this population. Second, reaching saturation in the qualitative data. So for those of you in the room who this is a brand new concept, this whole qualitative research thing, saturation is defined as when the responses that are coming in have become redundant. They've become redundant. They've become redundant. Just kidding. So we reach saturation. We reach saturation in both the survivors and the parents, and we feel like we have a very good understanding of the barriers and facilitators in this population. So that's why you don't see a p-value, you won't see any significant stars or anything like that, but that's how we identify that we've made it in qualitative research. The online survey distribution allowed us to get a diverse sample from across the United States, and it was very feasible for us to do that. Some limitations, there's some possible selection bias because most of the participants were currently active or classified as active, and that will surprise Janice out at Emory. We talked about this in one of our meetings, that we have this problem in Colorado where people are already active and participating in our physical activity research. But that doesn't mean that this is not useful, because if these people are already active, then that allows us to get a better understanding of what facilitates their physical activity, and they can report what resources have helped them be physically active. An online survey, as wonderful as it is to get a diverse sample and is highly feasible, we were not able to probe or follow up on some of these vague responses that we got. So, and we'll move forward in future directions here in a second. Again, the parents and survivors were not dyads, meaning they were not matched. If they were matched, I think that we would get a better understanding we'd get the same information from a survivor and a parent and be able to know that those things are important for both. But we don't necessarily have that with this study. So, some future directions. Based on those limitations that I just mentioned, I think that semi-structured interviews and focus groups would be a great next step for understanding these barriers and facilitators. Including dyads would be very helpful. For us, we didn't include household income in the demographics, and we didn't actually know that we needed to, because this is an elicitation study, so this is a starting point. We have seen it in other populations, but we weren't sure if it would fall into this population. And because finances emerged as a top theme in the data, I think that it's necessary for us to then include that information in future studies. Additionally, quantitative survey development can definitely benefit from this study. So when you want to, if you want to start getting p-values and significance, you're going to need bigger sample sizes, and you get that through quantitative research. So one of the questions that I think would be a great way to incorporate basically the findings of this study is using a Likert scale question, meaning that on a scale of 1 to 7, 1 being the least and 7 being the most, rank the importance of the following factors in helping you engage in physical activity. Social support, motivation, an easily accessible location, and then this is where we would add financial resources. Is that to help pay for a program? Is that to help pay for a gym membership? Is that to help you understand ways that you can change your own financial situation and create some funds for physical activity as a financial priority for you? And then knowledgeable staff for managing cancer. So this is a sample question that could be used in quantitative research. With that, look at that, we're right on time. Some conclusions here. So adult survivors of child cancer are at greater risk of cardiovascular disease because of their cancer treatment compared to the general population. So it is critical for us to further our understanding of successful ways that we can be promoting physical activity, because we know that it helps and we know that it's good. So some factors that we know that help our survivors be physically active: proximity and access, being close to places to be physically active, having social support, whether that comes from at home, at school, or work, and equipment, having the equipment that's necessary, whether that comes from a gym, whether that comes from resistance bands at home. And then things that hinder physical activity: time and schedule constraints, limited financial resources, and health-related barriers. And then my final point is that they have already survived cancer, a diagnosis that most of us in the room will not experience. So let's help them thrive into adulthood. I would not be able to do any of this without my fans. So Dylan is my little buddy. He's my camper, my best bud, and a cancer survivor. In fact, I dedicated my thesis to him. The physically active trampoline people lab, just kidding, the physical activity for treatment and prevention lab, would not be able to do it without all of these people, including Dr. Leach, which we'll get to in a second. Some acknowledgements: my participants are likely not in this room. In fact, I wouldn't know if they were in this room. But I would not be able to present this without them. So thank you to them. Thank you to Ashley Clark, who helped me code all of the data. The department for continued support, my cohort of grad students who have laughed with me, cried from laughing and laughed from crying. The Colorado Graduate Grant allowed me to be funded here. The Human Being Coffee Truck for my daytime beverage choices, and Wilbur's for my nighttime beverage choices. My advisor, Dr. Leach, I would not be here today, and I would not be the writer that I am today without you, so thank you. And thank you to my committee for all of your time and effort in helping me create this project. So thank you. Oh, Janice is, I don't know where she is. And Riley and Brisket, rest in peace Brisket, rest in peace Riley, wow, woo, still have Brisket, for endless cuddles on the couch. With that, I'll open it up to the floor for questions. Yes, Nate?
So you showed a figure in the beginning that said something like childhood cancer survivors, like 40% meet physical activity guidelines.
Mm-hmm.
So if I remember correctly, that's more than the general population that meets physical activity guidelines. So what's the difference between these people and our general population? What are they doing right?
That's a great question. So, yeah, that's actually really interesting. So the research that I looked at was compared to healthy siblings, and so healthy siblings had higher rates of physical activity than their survivor siblings. And from what I understand, I'm not sure if the overall population meets guidelines at 30%. I want to say that it's closer to 50. I think that when looking at the healthy population, that it absolutely isn't I don't know, to be honest, I don't know what those factors are that would help them be physically active, because all of the research has said otherwise. Does that answer your question to some degree?
How much, maybe I missed this, what percentage of your participants were meeting current guidelines?
Yep, so the way that we measured physical activity was with a GODIN, which is a self-reported physical activity. And the way that it's scored is not based on physical activity guidelines, but by just activity level in general. So all that it allows us to do is stratify as active or inactive. So 77% of survivors were considered active. But when you look at what the score is to be that, it's like 2 times a day, or 2 times a week for like 20 minutes, or only for like 15 minutes at a time. So that doesn't necessarily mean that they are meeting those guidelines, but the measure that we used here to determine their activity only allowed us to stratify based on active or inactive. Clay.
I may have missed this, but what about the cancer treatments results in higher cardiovascular disease?
Yeah, great question. Yes, I'm just so excited that I can use a bonus slide. That's really all that I cared about. Treatment-related cardiovascular disease is the leading cause of non-cancer mortality and morbidity. So it's caused by anthracyclines, which are a type of chemotherapy. You might have heard of doxorubicin. What it does is it causes a whole host of cardiovascular problems, including left ventricular hypertrophy. There's some research out at UNC with Dr. Hayward, Adam Chico, I'm forgetting the other person, David Hydock, who have looked at, in mice models, what is exactly happening mechanistically with the cancer treatment and what's happening to their hearts. But the purpose of this study was to know, okay, this is a problem, we know physical activity can help it. How can we get them to be physically active? Dr. Fling.
Well, first, I thought that was a really nice talk. Second, don't call on my student before you call on me.
So this is what I told myself. I was going to call on people in the room who did not have a PhD before those who did, to allow those in the room who actually have questions to not be intimidated by those with a PhD. So it's your turn. The floor is yours.
Clay is easily intimidated, so I'm glad you did. I have a qualitative analysis question. Would you go back to your results slide? And your one slide, to your financial results slide.
Yeah. This one.
So just sort of generally speaking, how do you, maybe this is contextual within the questions and we don't have a chance to see this, but you have money as a response under barriers and under resources. So how are these grouped separately when they give the same answer?
Great question.
Thank you.
So, yeah, I was raised with a PhD, right? These were sorted based on the question. So if they answered the barriers question and said money or financial hardships or limited financial resources, then that was categorized as a barrier. If they answered the question if they answered what resources are necessary and they answered the question and said money would be a necessary resource, then it fell into resources. Jimmy K.
So this is also a qualitative research question. So you reach saturation, but I'm wondering how you think the demographics of your sample might have affected reaching saturation, and if your sample were different, how your outcomes might have changed. Specifically, I'm thinking about sex, because you had a highly, like 80% female.
So, great question. So in terms of, by the way, it was gender. We specifically made sure that it was a gender question. We got some help from Dr. Chart on that one. Shout out. So to answer your question, it could have changed. And so yes, you're right that the sample is mostly female. In terms of cancer diagnosis, I'm trying to think of I'm trying to remember what the percentage is based on male or female, and I'm not recalling off the top of my head what that is. I know that it's not 50-50, but I can't remember which way it leans. So if it were to lean toward more females, then this would be a representative sample. But if it doesn't, then yeah, then adding more men could possibly change that. But yeah. Wow, so many. Yes, Dr. Farner.
Beautiful reason to do this study. Lovely job. Super proud of you. My question,
Okay, you're done? Oh, no. Sorry.
My question is, do you think that there are important psychological reasons or barriers that this population might have that are very important? I'll give you an example. People that have had a MI, their motivation to exercise can be very challenging. The rate of depression in that population is much higher. They can be scared to exercise, even though you tell them, no, you're fine, you fixed it. And I'm just curious if you think, this is not, maybe it's not even known, do you think that there are psychological barriers in this group that would be important to know if you're trying to help them exercise?
Yes, so absolutely, I think that psychological factors definitely are a huge influence in this population. Some studies have actually looked at the rates of depression and anxiety in this population, and those would fall under the individual level of the ecological model. So, so yes, did we ask those questions specifically? No. And so we have, yeah, so to answer your question, yes, I think that it absolutely is a factor that should be included in understanding whether that comes from, maybe that support level comes from the microsystem. So with clinicians that are engaged in this population to help them cope with their depression, to then help them be physically active. So that would be a cool way to kind of involve the entire model here to address that factor. Janae.
Wait, was mine a good question? 'Cause you said.
You had it, yes, it was a great question. Wow, yes,
Wasn't as
round of
great.
applause for you.
That was good.
Yes, Janae.
I'm curious why you wanted to include parents in this, and I'm also curious whether there were differences in kind of the parents' perception versus the survivors' perception. So I don't think like my parents, they wouldn't have any idea how to answer physical activity.
So again, the reason why we included parents was to capture some of those factors that are outside of the individual. So because parents are along for the ride through their childhood cancer journey, most times parents are the ones who are getting information from the clinicians, and the survivors, depending on how old they are, clinicians will engage the survivors in those conversations, but sometimes that's not the case. So parents are what we call critical gatekeepers of information in a cancer treatment. And then also, so because of that, they have a different understanding of their survivor. And it could be, and the reason why I included this, hold on, I'm gonna mute this. So the reason why, what was the second part of your question? I got distracted.
I'm sorry. Well, yeah, so I'm just curious whether there's
Oh,
difference.
if there was a difference.
Because you're asking them the same questions. that
Yep.
You're asking the survivors, right?
Exactly.
Parents like perceive their children's barriers and resources and things like that differently than just these adult survivors.
Yeah, so that's a great question. So the parents and survivors reported very similar things. So what the survivor said and what the parents said, they all fell into, like when we were kind of stratifying by buckets, they were all like, we reached saturation in both. So they were saying the same things. In terms of, I had another thought and now I can't remember, so we're just gonna skip it. Yes, Patty.
So I was just wondering, what do you think, so these things that emerged on your barriers, facilitators, and inhibitors, how they would relate to, sort of like age match healthy adults that, didn't have a cancer diagnosis as a child. So like proximity, social support, equipment, finances, I could see as being, key sort of barriers why normal sort of healthy populations also physically inactive.
Yeah.
So what specifically sort of, makes these barriers, would it be much different from a healthy person, or so what specifically makes this sort of physical inactivity related to their cancer diagnosis as a child?
Yeah, great question. So proximity and access, social support, time and schedule, finances, all have shown up in healthy populations as barriers to physical activity, barriers to facilitators' resources. The reason why we chose, one of the reasons why I chose to look at this population in particular is there's not much research on this population. There's childhood and adolescent survivors, there's adult cancer, so breast, prostate, lung, but this intermediate of adult survivors of childhood cancer, there's not a whole lot of research that is out there with this population. So we could have just said, okay, yep, it shows up in other cancer populations, it shows up in healthy populations, we're just gonna assume that these are the same barriers and facilitators for this population. And what we found was in fact that that's not necessarily true. There are certain health-related barriers that are specific to their cancer treatment that have shown up as important for this population. Additionally, finances emerged, which is one of the new and novel things that is adding to this body of research, because finances has not shown up in this population before as a potential barrier for facilitator or resource. So that's what this study adds to the literature, and that's even though we know that in healthy populations that these themes show up, that's why we decided to look at this. Sarah.
I kind of have a two-part question.
Okay.
So you have a pretty wide range, about 20 years of adults that you surveyed, and you mentioned you looked at radiation and chemotherapy. From what I mean, I'm not an expert in cancer treatments, but I do know that there's multiple types of radiation, there's multiple types of chemotherapy, and I also know those are changing all of the time. So could those different types have affected your research, and is there any variables that you might have accounted for to say like, oh, well, this radiation might be treated differently, especially since there's so many combinations of treatments nowadays, and it's a pretty wide range. So somebody who's 39 might have gotten a treatment that's no longer even around, where somebody who's 18 might have like the newest, latest, greatest treatment.
Okay, so I'm going to answer that first part in two parts. Stay with me, everybody. So the first, look, I get to use another bonus slide. I'm so excited. Okay, so this is the cancer therapies that were reported by survivors and parents. So 100% of all the participants received chemotherapy. The second highest was surgery. Yep, surgery and then radiation. And the totals here are greater than 100%, and that's because most of them received more than one therapy, so that's why the numbers are off. So yes, they all did receive chemotherapy, and most of them received radiation. There's no way for us to know without looking at their medical records of what type, because most of them don't actually know the exact type the type of radiation, the dosage, all that kind of stuff, and it's best to actually use something like EPIC or ENCORE to capture that data instead of being self-reported. The second part to your question is that the reason why I chose this age group, which like you said, spans almost 20 years. And that's because the NIH defines adolescent and young adults as 15 to 39 years old. And so the target journal that I hope to publish in is the Journal of Adolescent and Young Adult Oncology. So I chose to make sure that my parameters for my study were included for publication in this journal. So, but to answer the different radiation types, that really just would have to come down to, you'd have to look at EPIC and other medical record databases to understand maybe some of those discrepancies, but we didn't capture that in the study. Did you have another question?
No.
Okay, cool. Zach.
So I might have missed this, but where were the responses all from? You said it went across the country. Is there kind of a proportion map of that?
Another bonus slide. Okay, so where in the world? I mean, United States, where are they from? They all were in the United States. The top, most of them came out of Colorado, so like 40-ish%. We got responses from Washington, Wyoming, Virginia, Oregon, Texas, DC, and then 6 of the participants left it blank. So we don't actually technically even know where they are. They could be outside of the United States, who knows? Yes.
That confuses me because now it doesn't jive with your statement that, well, these people are physically active because they live in Colorado, and most of them didn't live in Colorado.
So a portion of them live in Colorado. Also, those who decided to enroll in the study it could be, that comes back to the selection bias, that it could be that they chose to be involved in the study because they were already physically active or they're interested in being physically active. So that could be a reason why most of them are active. Colorado was the top, location where the most representative of.
Now, you mentioned this, but since Kelly's sitting right here, and you know what I learned from Kelly's publication, which is almost ready to be accepted, I'm guessing, is that close is the influence that the oncologist can play in either recommending physical activity or directing people to resources for physical activity. And where does that fall in your buckets? If somebody reported that a barrier was my oncologist didn't talk about it, or a facilitator was my oncologist recommended somewhere to go, is that a health-related barrier, or is that a social support? What bucket did you put that in?
Okay, so surprisingly, clinicians did not show up in the responses. I expected. Yeah. Sorry, Scott. Clinicians.
Not an oncologist.
Yeah, no, yeah, not an oncologist. He's an anesthesiologist, pretending to be a cardiologist by day. Yep. Oh, I almost got it. Okay, so to answer your question, we expected that clinician influence would show up. It's shown up in child and adolescents. It's shown up as an oncologist in adult cancer research. We fully expected it to show up. And we would have put it in the microsystem, because that's a person that this individual engages with that is outside of themselves, unless they are an oncologist themselves. It's a person that they engage with, so it would fall into the microsystem. But it didn't show up. Clinician influence didn't show up. And one of the reasons that we think that it didn't show up is because they are now adults. So most of them, let me pull this up. Okay, so their time off therapy, this is their time away from their cardiologist, or away from their oncologist, was on average 15 years, 14, 15 years. So we're asking about their current physical activity. So it makes sense that they didn't report, oh, my oncologist said so 15 years ago, and so that's why I'm still being physically active. That didn't show up. And we think that that's likely because of this population that had cancer 15 years ago and are now adults. So that's one of the reasons why. And then we actually initially thought about including clinicians in our survey to get their perspective, to understand, okay, what are you saying? How do you perceive the barriers that your patients are experiencing? And we actually chose not to include them. And that was because clinicians, to Sarah's point, clinicians today are using therapies that are right now. And they are having conversations about physical activity more than they did 15 years ago. So it wouldn't make sense, it would be more of a confounding variable to include them in this study, because because our study was retrospective in terms of their cancer treatment, that if we were to include clinicians today, they wouldn't give the same information that the survivors would. Any other questions?
All right. We're good.
Thank you guys.